Again, good morning. Let me welcome you, as I've said again, because I gave the welcome remarks. And so, for my part, the lecture is entitled Pediatric Updates, okay? Pediatric Infectious Disease Updates for 2009. But let me caution you that these pediatric infectious disease updates will not really cover everything. I've chosen only a few of them because I have to have a short talk to give way for all the other luminaries that we have. So I've chosen a few, and this will consist of the H1n1 Pandemic Flu, influenza of 2009. Then we do have the Leptospirosis that we've had this lately. And then the other thing would be for the latest dengue reclassification of the criteria for diagnosis. And of course, the antimicrobial resistance pattern that we've seen for the year 2007 and 2008. And the last would be the changes or revisions that we've had in our immunization schedule for 2010. Okay? So to start with, I have the H1n1 Pandemic Flu. Okay? Well, in March of 2009, last year, Mexico has been having a lot of cases of respiratory infections that were reported. Then it went on to April, and CDC was, very vigilant about this thing. And so by April, they were able to note and identify 2 children in California because they were ill due to a novel influenza A H1n1 virus, which was presumed to be of a swine origin. It turned out to be it's a reassortant of human, swine, and avian virus. So, but since then, these patients did not have any history of exposure to pigs. However, because of the 2 children that did not have any exposure and yet got the disease, the possibility of a human-to-human spread is there. And therefore, a threat for the dissemination of this virus to a pandemic level is there. So, as observed, there was a movement of this virus causing several patients in April again, in Mexico to have acute respiratory disease, and again were identified to have the novel H1n1 virus. With this, and the large number of patients that were affected, and the movement towards the United States and other parts, on April 27, the Pandemic Alert 4 was raised. 2 days later, the Pandemic Alert Phase 5 again was raised. By May, the Philippines reported the first case of H1n1. So this means that other regions are now really becoming involved. Now, you call a pandemic on a pandemic alert phase when majority of the WHO regions will have reported H1n1. And so, on June 11, 2009, a pandemic alert phase 6 was raised. Now, 15th of June, it was reported that there were 76 countries reported to have 35,928 laboratory-confirmed new cases. And this included 163 related deaths. In October, the Philippines had documented 4,549 cases, with the majority of them in the age group of 10 to 19 years. So these are adolescents. And 28 of the deaths were those found to be 50 years old with underlying illness. Okay. With this, there was a review on how the disease presented. It was seen that the disease can present as a non-febrile respiratory infection. Okay, so Or maybe they can be with fever, with body malaise and headache, mild upper respiratory tract illness, which is manifested as cough and sore throat. And then at times, there will be progression of the disease within 5 to 6 days after the onset as a primary viral pneumonia and eventually leading on to a multi-organ dysfunction syndrome, and was found to be mostly found on obese male. So pregnant women were also noted to have this. So this was a fatal thing, you know. It's not good to be obese and get the H1N1 virus. It seems to be that is what's seen here. And GI manifestations were also seen to accompany the infection. So nausea, vomiting, and or diarrhea were found in some of the patients. Now, since this is pediatrics, we will focus on the pediatric deaths that were reported. Yes, so they were able to show that there were two groups of those who had mortalities. These children were those who are less than 5 years of age and those with high-risk chronic medical conditions. So these were the two groups where pediatric deaths related to the H1N1 virus was seen. Now, there were also deaths for those healthy children more than 5 years with severe fatal outcome, but they were shown to have co-bacterial infection. So they were co-infected with bacterial infections. Okay. Now, the other thing that was reviewed was that concomitant infection with seasonal flu. Okay, so influenza-associated pediatric mortality. Since August 30 to October 31 of last year, they reported 236 deaths associated with laboratory-confirmed influenza infection. Okay. 83% of those patients were cases that have been confirmed, laboratory-confirmed at that, for the 2009 H1N1 virus. Okay. 40 of the pediatric deaths were associated with influenza A infection, and 1 death was associated with influenza B virus. Now, of the 236 patients according to age group, okay, it was seen that about 29.2% belong to children 4 years and below. Okay. And the rest, about 70% of them, would belong to the age group 5 to 17 years of age. So you just can see that, you really have the pediatric age group, be the very young and the adolescents are really affected or are likely to have a associated mortality when they are co-infected with the seasonal flu, having the H1N1 and the seasonal flu at that. Of course, everybody knows that this is a self-limiting disease. However, antiviral agents are utilized for treatment of patients who are at a risk of a fatal outcome or a severe outcome. And there are those also who have high medical indications or are high risk, who are supposed to have chemoprophylaxis. And one indication is that if they cannot be vaccinated, if the vaccine is available for H1N1 and they cannot be vaccinated, then chemoprophylaxis can be utilized as an alternative. Okay. The antivirals that have been available for years has been rimantadine and amantadine, and they were utilized for seasonal flu. However, H1N1 is 100% resistant to it. So you cannot utilize rimantadine and amantadine at all. Okay? There are other two alternative antiviral drugs, oseltamivir and zanamivir. We do not have zanamivir. Okay? It's not available locally. It's only oseltamivir. Okay? So that's the antiviral. As I've said, I will not deal, lengthily on this. I'm just a teaser, as I've said to Dr. Navarro. So, the cornerstone for the prevention of flu infection is vaccination, whether it's seasonal or pandemic flu. Okay, to address the pandemic flu, H1n1 pandemic flu vaccine should be developed and made available. Okay? This vaccine has been, the manufacture of this has been, I'm so surprised because they're putting a 5 minutes, time limit for my talk. And said, the vaccine has been developed right away to address this problem. And so, it has been made available. The vaccine has been utilized in some countries in the world. Now, the vaccine, please, public health authorities and vaccine manufacturers have agreed that vaccines will not be available to the private market. The government will be the one to decide who will receive the vaccination. Okay? So for the moment, what we can do only would be to utilize these preventive measures that we have: social distancing, hand hygiene, respiratory etiquette, home isolation for mild illnesses or as soon as you have flu-like manifestations. Okay? The next is leptospirosis. This is what you have seen in September 26 of this year. Okay? You can see the flood, all those things. And this is what was seen. Of course, when flooding occurs, everybody, is evacuated. So when evacuation was done, the government did follow up what happened in the evacuation sentinel areas. And so what happened was that they were able to note that there were increased incidents of acute respiratory illness, skin infections, wounds, where, PFB, through Dr. Chet Gonzalez, prodded us to make available the tetanus vaccination, for these people. So, febrile illnesses, influenza-like illness, and acute respiratory illness and pneumonia. These were the things that were seen. Okay? However, it was noted that there was an increased incidence of leptospirosis because people were wading in the flood together with the rats. Okay? So, as you know, that this thing, leptospirosis, is through the contamination, water, and also the getting in of the virus into wounds that are abraded or skins that are abraded. So the DOH asked the Philippine Society for Microbiology and Infectious Diseases to issue an interim statement on the role of antibiotic to prophylaxis in leptospirosis. The pediatric was not, called for because the drug is a tetracycline drug. Okay? And there were very few pediatric patients compared to the adult cases that were seen. Okay? So the antibiotic prophylaxis for leptospirosis may be achieved by the administration of doxycycline depending on the risk category of exposure. So it has, the slide is this, where you categorize the patient into low risk, moderate risk, and high risk. And this depends on the exposure to contaminated water or flooding. No? So the low risk is you have a single, history of wading, plus no wounds at all, absence of wounds. Okay? You have the doxycycline, only single dose, and within 24 to 72 hours. For moderate risk, you have a single history of wading in the flood or in the contaminated water, but you have a wound here. So therefore, what happens now is the doxycycline is now to be given for 3 to 5 days. Okay? Again, within 24 to 72 hours from exposure. So the high risk, continued exposure. Okay? And you have to give the doxycycline once a week until you are out of exposure. So that is how they did it. For the children, doxycycline may be given only for children 8 years and above. But we've raised the contention that if it's only a single dose, it won't do any staining at all, even for the 3 to 5 days, because it is supposed to be dose-related, no? The staining of the teeth and all those things, and chelation of the bone, are all related to the dose. Okay? So this is what that caused that thing was the Typhoon Ondoy, and by November 5, there were 210,816 families, 1,103,569 individuals who were still residing in flooded areas in 152 barangays in 29 municipalities of the National Capital Region and the Region 4A. Okay? So leptospirosis cases from NCR and the different regions as shown here totaled 3,125 cases with 240 cumulative mortalities. 73% of the cases were from NCR. Okay, for the dengue, this I will just only have one slide. Because the next speaker is going to talk on this lengthily. The classification of dengue has been revised. The revision was done, by after doing the study in 32 countries. Okay, there were 32 countries who participated in the dengue control study, and the Philippines participated in that with San Lazaro as the sentinel site. Okay. So this is how it is. It just looks like your IMCI, your Integrated Management for Childhood Illnesses. It says dengue with or without warning signs, and then dengue, severe dengue, but with the presence of plasma leakage, hemorrhage, or organ impairment. Okay? So I will leave it at that because Dr. Rose Capeding is going to talk on this. Okay? So... Okay. Well, I won't go into that anymore. So the antimicrobial resistance rates, okay? Well, I'm just going to compare the 2007 and 2008, and it's just a few things. Enteric pathogens tests were done for Salmonella typhi, non-typhoidal Salmonella, and Shigella, and Vibrio. In this report, Salmonella typhi did not show any resistance to chloramphenicol for 2007 to 2008. Okay? Meaning to say, you still can utilize chloramphenicol. With ampicillin, you still can, but, it is an alternative drug only. So for the non-typhoidal, of course, all of us knows that when the patient is healthy, you don't need to give any antibiotics for those gastroenteritis secondary to that. But for those with risk factors for bacteremia or disseminated infection, you will have to give, usually you have to give antibiotics. And it is shown here that there is no resistance to ciprofloxacin, and there is even an increased sensitivity to chloramphenicol. For Shigella, you will see, even in the next slide, that Shigella is highly resistant to ampicillin, chloramphenicol, and cotrimoxazole. But no resistance to nalidixic because we don't have the drug. So therefore, no use with it, no resistance. Okay? For cholera vibrio, no resistance to tetracycline. So you still can use it. Okay? So this is the ones that I've shown you, was saying. Okay? Tetracycline there. Okay. So this is just the same. For the RE pathogens, okay, the nice thing about this is I'll show you the next slide. For Streptococcus pneumoniae, there is no resistance. Strep is highly sensitive to penicillin. There. Okay? But Haemophilus influenzae, sad to say, the resistance is increasing for almost all. There, Haemophilus, ampicillin, chloramphenicol, Cotrim, and okay, that's it. So, to Moraxella is resistant to almost all, okay, of those that were studied there. Okay, and generally, some would utilize this, but as you can see, it's 32 and 36 resistant, no, to erythro. Okay, so for staph, this is it. So you can see the resistance, except for Cipro and cotrimoxazole for Staph aureus, still sensitive to the organism. So with erythro and vanco. So those are the drugs, no, for which the organism is still sensitive to. Okay? Let's go to the Staph Epidermidis. Oh, excuse me. They are highly resistant, of course. And then to Cotrim. Okay? And then there. Except to vancomycin only. So what does this slide tells you? If you're encountering a staphylococcal infection that is really very invasive, then don't utilize first and try the most, the intermediate ones because it's cheaper. In the long run, it becomes, very expensive and may turn out to have a fatal outcome. So you use your vancomycin. So the Enterobacteriaceae, okay? Here's for the E. coli. So don't use ampicillin when you are having an E. coli infection because you can see the resistance. 78% almost is the resistance. Resistant also to Ampicillobactam. Okay? There is your resistance pattern, almost all. Okay? So this slide tells you amikacin, will be the only one that is quite sensitive, the E. coli is very sensitive too. For Klebsiella, all of these drugs there are all resistant, except for imepinium and cefepime, still you can use because it has not reached the 10% level of resistance. Okay? For the Enterobacter, I'm sorry. Oh, there, resistance again. It's all resistant, so of course that's expected. And imepinem, you still can use. Okay? So the thing. For pseudo, you can see here, resistance is there. So with this one, almost all. Okay? There. Okay? So for gonorrhea, you can use cefixime, ceftriaxone, and spectinomycin. So, highly sensitive. Okay? So, this is my last slide, the childhood immunization schedule for 2010. I just would like to show you the 2009 so that you will see the difference. I don't have a slide like this for the 2010 because it's supposed to come out at the PPS convention. So, it has not been printed yet. If you will notice, this is how it is. The pink box contains the EPI vaccines and it is only up to measles. Okay? For this year, Hib and MMR will be included. So your EPI is now expanded to have EPA, the Hib and the MMR be given in the public market. Okay, so that's it. Now, a lot of murmur. Okay, that's just what I want to show you. The front of the card, the immunization card. The back is the annotation. So please read on those annotations, no? Because I am going to take this up with you. The changes and revisions and additions that we have. So the red one is MMR and HIV in the EPI vaccine schedule. Okay? We placed the N there for the pneumococcal, just to complete it, okay? This one, the measles MMR, is missing in the annotation in the previews. That's why we added that, okay? There's really no change in it. Just included it in the annotation. However, this one is added because MMRV is already available, okay? And so, this combination may be given as an alternative to separately administered MMR and varicella vaccine. Okay? So, for the flu immunization, our schedule last year was only up to 5 years. Because of the pandemic flu, universal vaccination has been recommended. And so, therefore, our schedule to give the vaccine would start as early as 6 months up to the whole age group of 18 years old and 364 days. For the HPV, before this age group was 10 to 55. We've decided to put only up to 18 because that's the age group we cater to. Okay? The others are only catch-up vaccination. So, that's why we took off the 55 and just retained the 18. Okay, that's the change that we have. The other thing, they ended it. Because it's just finished. Okay, but I would just like, because really there are really not much change in the schedule except only for that addition of MMRV and for the influenza vaccine where we extended up to 18. Okay? So, thank you so much for listening and I made you laugh at least.